A busy general practice manages cases of diarrhea and abdominal pain every day. These symptoms represent some of the most frequent reasons patients seek medical advice. Because these symptoms are nonspecific, clinicians often fall into a cognitive trap. The immediate diagnosis frequently defaults to a transient gastrointestinal infection or irritable bowel syndrome. That clinical overlap has significant consequences. Patients actually suffering from inflammatory bowel disease often face a diagnostic delay lasting between 1 and 8 years. During that delay, patients endure explosive diarrhea, rectal bleeding, and profound fatigue. The resulting social isolation can be as debilitating as the physical symptoms themselves. Dismissing these signs as a persistent virus allows the underlying disease to progress. GPs must recognize when the standard pattern of infection fails to resolve and shift toward an active investigation. Breaking the cycle of misdiagnosis requires identifying specific red flags. Symptoms persisting beyond 6 weeks, nocturnal bowel movements, and unexplained weight loss change the clinical priority. These markers suggest an underlying structural inflammation that is actively damaging the gut wall, rather than a functional issue like IBS or a temporary infection. Identifying these specific indicators is the trigger that moves a patient out of primary care and into the specialized diagnostic pipeline. The investigation begins by excluding other causes. Stool cultures rule out parasitic or bacterial infections, while blood tests identify systemic inflammation and iron deficiency. Fecal calprotectin has become an essential non-invasive biomarker for these cases. When the gut is inflamed, white blood cells migrate to the intestinal wall and release these proteins into the stool, providing a measurable signal of localized inflammation. Elevated calprotectin levels necessitate an urgent referral for a colonoscopy with tissue biopsies, which remains the diagnostic gold standard. The procedure identifies the disease phenotype. Ulcerative colitis is defined by continuous inflammation confined strictly to the mucosal surface layer of the colon. Crohn's disease presents differently. It causes patchy, transmural damage that penetrates the full thickness of the bowel wall and can occur anywhere from the mouth to the perianal area. Mapping the exact location and depth of this tissue damage is the necessary first step before selecting a treatment strategy. Modern IBD management centers on achieving deep mucosal healing. Clinicians aim to stop the cellular damage entirely to prevent permanent structural scarring and long-term disability. For mild ulcerative colitis, treatment often begins with 5-ASA medications. These work topically to reduce inflammation on the surface of the colonic lining. These British Society of Gastroenterology guidelines suggest systemic corticosteroids as a short-term intervention to rapidly induce remission. However, as the implementation considerations explain, due to significant side effects, they are strictly restricted to an 8-week window. Long-term maintenance relies on biologics and small molecules. These therapies are engineered to block specific inflammatory pathways, effectively neutralizing the body's autoimmune response. Surgery, including bowel resections or colectomies, serves as a proactive intervention for refractory disease. It is used to remove damaged tissue and restore a patient's physical autonomy when medical therapy is no longer effective. Successfully managing IBD requires this targeted escalation. Delays in treatment allow for irreversible structural damage to the bowel. While clinical remission is the primary goal, IBD remains a lifelong condition. Maintaining that state requires permanent clinical guardianship. Patient symptoms do not always correlate with disease activity. Clinicians must use objective surveillance, such as regular calprotectin tests and intestinal ultrasounds, to catch silent inflammation before it causes scarring. This maintenance phase also involves managing the risks of long-term immunosuppression. Protecting the patient requires a proactive approach to systemic health. These guidelines detail the specialized immunization schedules required for immunocompromised patients. Clinicians must manage non-live vaccines for influenza, pneumococcal disease, and shingles to prevent opportunistic infections. The care plan extends to monitoring bone density, checking for dermatological risks, and providing psychological support to address the anxiety often associated with chronic disease. IBD is a formidable condition, but the combination of rapid detection, targeted biologics, and vigilant maintenance allows patients to stop the inflammation and regain control of their lives.